Hello everyone, welcome to our event tonight. I'd like to thank you for coming tonight and joining us for our second CPD event for the St George Hospital Grand Rounds Practice Nurses Series for 2024. Tonight's topic is ECG Essentials for Practice Nurses. My name is Jan Sadler and I am the Manager of the Practice Support and Development Team at CESPN. Also with us today from CESPN is my colleague, Michaela Fennick, our Practice Nurse Liaison Officer at CESPN, and you probably all know her very well. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise a continuing connection to land, water and community and pay respect to elders, past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander people joining us tonight and invite you to complete this 2025 CPD planning survey. It's quick and easy to complete, take approximately 5 minutes. Your responses will be kept confidential. It's a chance to win a $100 voucher and that's awesome. And it closes on the 28th of October, so please do that. Don't forget, our practice support team and our digital health team and immunisation team are always here to help, so please reach out for any type of support across your general practice. So I think we'll get started. I'd like to introduce our speaker for tonight. This is a very exciting topic. It's one of those topics that comes up in a lot of our feedback, ECG essentials and interpretation. So please welcome Glenn Paull, who is a clinical nurse consultant for cardiology at St George Hospital. Thank you so much, Glenn. I'll hand over to you now.
Thanks very much, Jan. And thanks very much, Jan. I'd also like to acknowledge that I'm presenting from Dharawal land and pay my respects to elders past, future and emerging. So it was really pleasing to hear that everyone's excited about learning about ECGs. As Jan said, I'm the cardiology nurse consultant at St George and have been for the last 20 odd years. And ECGs are something I feel quite passionately about and always happy to talk about and to try and explain some of the intricacies of the ECG to help all our understanding. So what I thought I'd cover today, and feel free to ask any questions as Jan said as we go along, is ECG essentials for practice nurses. So first of all, what is it and why do one? We'll go through some tips on recording a 12-lead ECG and look at some troubleshooting. I suppose also we'll look at the ECG essentials. There's some things you just have to know in order to be able to make more sense of ECGs. We'll look at basic 12-lead ECG interpretation from those essentials. We'll touch on myocardial ischemia and infarction, and also we'll look at some common abnormal heart rhythms, looking at some bradycardias and tachycardias. And I suppose we're never going to cover the entire gamut of ECG sort of top topics in a relatively brief session, but hopefully we'll be able to sort of just gain a greater understanding about the ECG and its roles and the role it plays. I suppose I've put this slide up a lot. I've been just nursing for 40 years and the longer I nurse, the more Florence Nightingale makes sense. And I really like this sort of quote. The most important practical lesson that can be given to nurses is to teach them what to observe, how to observe, what symptoms indicate improvement, what the reverse, which are of importance and which are of none. And there's a little bit of a association with Sherlock Holmes with that power of observation. And I think an ECG is a good example of that, because you do need good powers of observation and you need to know what to observe. So I hope we'll be able to make some progress there. So I suppose there's a hint to what the electrocardiogram is by its name. So electricity, cardio, heart and gram visualised. We're visualising the heart through its electrical impulses. So it's the electrical representation of the mechanical activity of the heart. And it's the most common clinical tool that we use for the detection and diagnosis of heart disease. So not only in general practice, it's very important. It's important in hospitals and in in like the management of coronary artery disease. So what can we detect? Well, we can detect arrhythmias, like common arrhythmias that we see all the time in general practice and in the hospital setting, atrial fibrillation, heart blocks, and offering explanations to people's symptoms. We can detect ischemia and infarction, myocardial infarction, myocardial ischemia. We can detect things like pericarditis, chamber hypertrophy, atrial hypertrophy, and ventricular hypertrophy, which might be in response to sort of chronic conditions or acute conditions. And we chronic like hypertension or valvular stenosis. We can look at electrolyte disturbances, so things like hyperkalemia, hypercalcemia. We can look at, and as well as drug toxicity. It can give us some clues as to the drugs which might be toxic levels in the body. And I suppose the one which comes to mind for me is digoxin, and that's readily like detectable on an ECG. So there's lots of reasons. There's lots of things that we can detect, and there's lots of reasons why we should be doing ECGs, particularly in primary care. So I suppose, when do you do them? Well, I mean, as a nurse who goes down to emergency, often seeing people who've been sent in by general practice, we always like to have a baseline. So having a baseline ECG of, particularly people as they get older, because the risk of coronary artery disease increases with age. So baseline's always good. People who present complaining of chest pressure, chest pain, that's another good reason to do an ECG. Complaining of fatigue. We know that people complaining of fatigue may be having some bradyarrhythmias or even some tachyarrhythmias, quite common in atrial fibrillation. People who are experiencing palpitations, so they feel their heart beating strongly in their chest. Once again, we'd want to do an ECG to see if there's any abnormalities. People who are presenting short of breath, that may be due to poor cardiac function and getting a backlog of blood back into their lungs, so they're short of breath. So we'd want to determine, is that a sign of ischemia? Is it a sign of a tachyarrhythmia or bradyarrhythmia? Dizziness and syncope with people with heart blocks or with fast or slow heart rhythms, and we can go into that a little bit later. And also pre-surgery or procedure, often we want ECGs prior to people having a procedure, just so we can compare it if they have any subsequent events. We want to go back and see if there's been any change. So there's lots of reasons to be doing an ECG in primary care, and there's lots of things that can tell us. So we'll progress on. So when we think about recording a 12-lead ECG, to be perfectly honest, I see a lot of ECGs being done, and probably the majority of them aren't done very well. That's across the board. People seem to get the limb leads okay, so that right arm, the left arm, the right leg, and the left leg, and they can be either at the shoulders, at the lower abdomen, as is displayed here. They can be further down, on people's arms and legs, and that's certainly what we used to do. But that does increase your chance of getting interference through muscle tremor. So they're fairly straightforward. They can be, as I said, they can be on the extremities of the limbs, or they can be really on the torso there. People tend to have more problems with the chest leads, and that's those V1, V2, V3, V4, V5, and V6. And that's where it's just really, it's anatomical. It's as simple as that. So we go for the fourth intercostal space down, either side of the sternum, that's V1, V2. Then the next one we'd look at is V4, which is in the mid-clavicular line at V5. V3 goes in between 2 and 4. And then a straight line then to the anterior axilla is V5, and then mid-axilla is V6. For some reason, people like to re-drag them all the way down the rib cage for some reason. I don't know why, but that's what they they tend to do an emergency, and everyone just likes that long drag and things. But there's actually that horizontal line between 4, 5, and 6, and so they make up the chest lead. And that will give us a lovely ECG. So this is an example, an exceptional example of a 12-lead ECG in all its glory. We can divide it up into the limb leads and chest leads. We've spoken a bit about the limb leads, so that's 1, 2, 3, AVR, VL, AVF, and then the chest leads being V1 through to V6. The limb leads look at really the heart through the vertical plane, whereas the chest leads are just straight through on the horizontal plane. And we'll go through a little bit about the different views they offer us and why that might be beneficial. So I think it's probably useful to look at how the impulses are formed. So in a nutshell, if you've got an electrode, any impulse going towards that electrode will result in a positive deflection, and any impulse going away from that electrode will result in a negative deflection. And you can see a little about that in this diagram, where we see the wave of depolarization in the gold arrow. If it's going towards the electrode, it's a positive deflection. If it's going away, it's a negative deflection. And anywhere in between, you might see it coming towards and then leaving. So those at right angles to it will be a little bit positive and a little bit negative.
So Glenn, we've just got a couple of questions, sorry, that have just popped through.
Right.
We've got, does it really matter if a patient is wearing jewelry?
Not really. If it's not going to interfere with the placement of the electrodes, obviously if they've got, you know, half a dozen bangles on their wrist and that's where you want to put the arm lead. But no, I don't think it matters a great deal. I think the most important thing, which we'll go through in a little while, is that the patient's, you know, relaxed and you get good contact with the electrodes. I think trying to minimise any electrical interference is important, but most of the time they're not going to be exposed to a lot of the electrical interference on the bed. So if you find that really it's a disaster, you know, you can try taking the jewellery off, but in my experience, no, it doesn't make a great deal of difference.
Okay, and I've just got one more here. Yeah, there's we've got somebody asking, have you any tips for placement of the leads for ladies with larger breasts?
Oh, look, that's a $64,000 question. Yeah, look, it's very difficult. I think there is some school of thought, is it on top of the breast or do you lift the breast up and place it underneath? Obviously, it's going to be very difficult. It's going to be very different for different anatomy. I think you just try and do your best. The most important thing is consistency. So we often do multiple ECGs if we're concerned about someone. So we're more interested in change. So we would just think, okay, you know, one person, if you get 3 people, they might put the leads on slightly different with someone with large breasts. I think that if you just try and get it as roughly as good as you can, and I think that's okay. And if you need to do repeat ECGs, well then, as long as they're staying in the same spot, because what we're looking for is change over time. But for that initial one-off ECG, I think you try and get it as anatomically correct as you can. If that means that maybe you're able to lift the breast up and place V4 and V5 underneath the breast, and then V3, V4 underneath the breast, and 5 and 6 maybe more towards the axillary. If that works, that's fine. If you find that's too low, or it can go on top of the breast. What it's doing, it's actually getting that impulse from, you know, from like the heart. So I suppose as long as it's as anatomically correct as you can, if that's below the breast, that's fine. If that's above the breast, that's fine too. You hear this often, and I was involved in like a state working group where we did some education for, which I've actually tried to get access to for practice nurses, but it's a nightmare. And that was the topic of much debate. So I think, just whatever you feel gives you the most accurate anatomic position.
Okay, great. Thanks, Glenn.
Okay. Yes, please just interrupt me anytime. So I think that electrode, so when you can come in towards an electrode, it results in a positive deflection and away is negative, is really well, there's a great example with the chest leads, which you can see in V1 here, you've got a very small R wave, and then most of it's going away. And that's because if you look at the mean direction of the heart's depolarization, which goes from the right shoulder down to the left of the thorax, it's actually going, most of that impulse is going away from V1, so V1 will be negative. But then as you transition, and this is called R wave regression, and that is as the R wave goes across the chest, it should go from negative to positive. And that's just because by the time it gets to V6 is actually coming towards V6 entirely. So that's why you get that positive deflection in V6. But I think it just exemplifies that notion of that anything going towards an electrode is a positive deflection, and anything going away from an electrode will result in a negative deflection. It's also important to label the ECGs. Often we have mislabeled ECGs, and they're the wrong patient, or this is an example of a mislabeled one. This is actually an American Pit Bull Terrier. That's why there's so many P waves. I don't know why they have so many P waves, but labelling is important, and the context of the ECG is important. So whenever we do an ECG, it's always good to say, look, they were having chest pain, or they're at rest, no pain, or they're experiencing palpitations. And if that context is put on the ECG, it just gives the reader a lot more information about the clinical context of what was happening whilst that ECG was being taken. There can be artifact. This is just artifact by people moving or not being settled. This isn't really electrical interference. This is someone who's, I don't know what they're doing. That's just like artifacts, and that's a challenge we often have. And I think we'll go through how to get the best ECG we can, but I think it's all in the preparation. So I suppose the top tips for a good ECG trace is, I suppose, there's no shortcut. So if you've got someone who's really hairy and oily, it's probably not going to end well. So I think shaving the excess hair will save you a lot of time and trouble, and good skin prep. So making sure it's nice and clean, not too oily. You can do some methylated spirits, sort of swabs, and to get rid of any excess oily skin. So that's really important. And often that takes time, and you try and cut corners, but it, as I said, never ends well. So good skin prep's important. Using quality electrodes and having good electrode patient contact is important, which comes back down to the skin preparation. You can use an artifact eliminator on the ECG, excuse me. And also really importantly is one, the patient has to be comfortable. So if they're in a freezing room, that's probably not good because they'll be shivering. But like I'll always tell people, if you could just like relax, just go nice and floppy. Some people say to keep still, and that might result in the person being really rigid and trying to keep as still as they can, which is actually tensing their muscles because, as we remember, like the ECG is just electrical activity. So the electrical activity we want is from the heart. We don't want it from skeletal muscle. So we just want all the skeletal muscle to be relaxed, and the only heart muscle electrical impulses which are coming through are the ones we want. So they're just and there's no really there's no sort of shortcuts to that, but my tip is good skin prep and just taking another 5 minutes to prepare the patient, make sure they're warm and make sure they're comfortable. So that's sort of, I suppose, during the 12-lead ECG, everyone's going to have different machines. When it comes to the interpretation, it's really, there's a few things you just have to know, and it just makes your life a lot easier. There's not a lot, there's a few things you have to know. So we'll just go through a little bit about the conduction system first. So as you know, just revising the conduction system of the heart, what should happen in a normal heart is the sinoatrial node fires an impulse, and that's the start of the depolarization of the atria, which is the P wave. And so the atria is depolarized, they pump the blood down into the ventricles through the tricuspid valve and the mitral valve. There's a delay as that electrical signal to depolarize goes through the AV node, and that's to allow the blood to empty from the atria into the ventricle. And then after that delay, then the ventricles contract, they depolarize and pump the blood to the body or the lungs. So that's the sequence that should happen. So from the sinoatrial node, depolarizing the atria through the atrioventricular node, which does an excellent job in slowing things down, because we don't want things going too fast at times. We want the atria, the opportunity to empty blood into the ventricles. Then through the His-Purkinje system and the right and left bundle branches, you have this specialized network which rapidly depolarizes the ventricles and causes the ventricles to contract. I can't emphasize enough that all this is ultra efficient when it's working normally, and it happens really quickly. And I think that then gives us a signal about when things go wrong, we can detect that. If there's delays in any part of this, we can detect where that delay might be, whether there's a delay in the ventricles or the AV node, or if there's a delay in the atria. Once again, this arrow is really signifying the direction of depolarization of the heart. So it goes really from the right shoulder down to the left abdomen, just in that direction. Is there any other questions?
We do have a few, Glenn, but I think we might keep them to the end if that's okay, just to make sure that we sort of keep going through. Yeah, thank you.
Great. Okay. So it's important to get to know your monitor paper. So you've got this grid paper. Each small square is 0.04 seconds, and each large square is 0.2 seconds. That's important because it gives you an idea about measurement and how we can measure that. So the horizontal line is time. So anything that gets stretched out just means taking longer to happen. So if this QRS gets stretched out, it just means the QRS is taking longer to happen. If that PR interval gets stretched out, it just means it's taking longer to happen. And the vertical is the amplitude. So I suppose the bigger the impulse, the bigger the muscle. So if someone's got a big atria or a big ventricle, lots of hypertrophy, you can get a larger impulse. The same is if they've got a diminished impulse, you've got less electrical signal coming from the heart and influencing the ECG. So this is important. So horizontal line is time. So that's just all happening over time. And the vertical line is amplitude. When we look at each component, so the P wave is the atria contracting. So you've got the SA node firing, so here, and then you've got the P wave, which indicates contraction and depolarization of the atria. You've got that PR segment, which is that where it's held up in the AV node. The atria contracts, goes through the AV node, which slows things down. And then once it's through the AV node, it depolarizes the ventricles, which is the QRS, nice and quickly because it's through that specialized His-Purkinje system. And then you've got the T wave, which is repolarization. of the ventricles. So P wave, the PR interval, the QRS complex ST segment, the T wave, and the QT interval is really important. That's associated with some drug toxicity, which we might keep an eye on, but we might talk about that a bit later. A simple method for calculating rate is that either it says on the machine, that's the simplest, or you divide. There's 300 squares in a minute, so you just divide the amount of time, the amount of lines by 300. So this is one line, so that means if the complex fell here, it would be 300 beats a minute. If it falls here, it's 150, here it's 100. So this one here is about 90. So you go 3, 150, 1, 75, 60, 50. So that's probably the quickest way to calculate heart rate. You just take 300 and divide it by however many lines there is between each complex, and that'll get you the heart rate. So having a systematic approach to the ECG is important. So is it regular? What's the rate? Is it fast or slow? I mentioned to all new staff who are coming to cardiology and they're a bit nervous about the monitors and things. Really, it's very simple. The rate's either fast or slow. What type of rhythm? Really, I don't think it really matters. It's just fast or slow. So if someone can tell me that, look, this patient, they've got a tachycardia, their rate's 130 and their blood pressure's 80 on 60, that's really all I need to know. And that's really good communication rather than getting too bogged down in the what type of tachycardia it might be. Just being able to communicate the rate is important because we know that cardiac output is stroke volume times heart rate. So if the heart rate's too fast, that's not going to give the heart ability to fill, and so it'll affect cardiac output. And if it's too slow, it'll affect cardiac output too. So what's the rate? And that'll give you a good indication as if the patient's going to be well or not, and then just maybe take the blood pressure. So fast or slow. So if it's 150, it's probably not good. If it's 30, it's probably not good. If it's bombing along at 70, everything's probably going to be fine. Are there P waves? You want to know if the P waves to see if it's normal conduction. So is this a normal sinus rhythm, which there should be P waves? It's sinoatrial node depolarizes the atria, and the atria is signified by P waves. Is there a QRS that follows each P wave? So is there communication between the atria and the ventricle? Slow down a little bit through that AV node. What's the PR interval? Is that normal? It should be less than one large square or 0.2 seconds, and that's the time along that horizontal line I was talking about earlier. It should happen within that time. If it happens longer than that, it just indicates there's a problem with the AV node. Is the QRS duration normal? So all these QRS should happen within 0.12 seconds, which is 3 small squares. So if everything's working well, if it's nice and super efficient, it'll be within those 3 small squares. If for some reason it's wider, it means there's a problem with the conduction system. So once again, that's a bit of it's a clue. It's a clue we're looking for. We're actually looking for these things. We're observing things which we know is going to tell us information. Is there a Q wave present? A pathological Q wave is something which is fairly wide, more than 1 small square wide, and more than 25% of that R wave. And is there any ST segment elevation or depression, which is going to indicate ischemia or infarction, which we're going to talk about in a little while? And is the T wave normal? Is it upright? It should be the same as the R wave. So if the R wave is positive, the T wave should be positive as well. So with the 12-lead ECG, there's the 3 bipolar limb leads and the unipolar limb leads, which are 1, 2, 3, AVR, AVL, AVF, and the 6 chest leads, as we've said. The reason they're important, the reason why we have so many leads, is we can just tell a rhythm through just one strip, and that's fine. You know, we can tell if they're in sinus rhythm or atrial fibrillation or whatever. We just need one strip to see what cardiac rhythm they're in. But when the idea behind the 12-lead ECG is we want lots of different views, and we can liken it to buying a car. Not that I've got an Audi, not that I want an Audi, but anyway. So if you're going to buy a car, you could look at this from the front, think, great, excellent, I'm going to put a deposit down on that. However, another view of that car could be rear-ended up the back, and it's the same thing with heart attacks. So we can have views of the heart which are normal on the 12-lead ECG that are looking at one part of the heart, but then the other part of the heart that's damaged will be hidden, and we need to look at other leads to ascertain that, and we'll go into those in a little while. But the 12-lead ECG is just giving us a good picture of the heart. We're looking at lots of different angles, not so much for the rhythm, so it can be useful to see the rhythm from different angles, but more so to see if there's been any damage, to see what the inferior surface is like, what the anterior surface is like, what the lateral surfaces are like. Of course, they're all fed by different coronary arteries. So if they have had a heart attack, if it's the right coronary artery or left anterior descending or the circumflex, they will affect different anatomical areas of the heart. And this is what I'm talking about. So this is a 12-lead ECG, and this is a bit of a rough idea. Well, not rough, it's pretty accurate. So the inferior leads are 2, 3, and AVF. Anything that involves AVF is inferior. So 2 and 3 actual and AVF all have that AVF lead in common. So that's inferior, looking up from underneath the heart. That's associated with the right coronary artery, and that's an inferior infarct. We know that's also associated with, also feeds the AV node, so sometimes they can get heart block. 1, an AVL, if you look at it from the left arm, it's high lateral. It's looking at the heart from that high lateral side, versus the V5 and V6, which is down on your chest, that's low lateral, which makes sense. So it's all lateral. AVL 1's high lateral, V5, V6 is low lateral, and then you've got the anterior and septal leads, which are going across the front of the chest. So you can see how it all sort of makes sense. You know, we're just getting all these different views. We'll plot some leads across the chest, so it gives us the anterior and lateral, and we'll be able to look at the inferior through those 2, 3, and AVF. So it gives us a good picture. And that's to detect ischemia infarction. So ischemia is typically characterized by this ST segment depression. The QRS complex should have this isoelectric line, but ST segment depression is signified here, that indicates ischemia. And also an inverted T wave here can indicate ischemia as well. So T wave inversion and ST depression, T wave flattening, can indicate myocardial ischemia, and you look whereabouts it is. On this ECG, you could see there's ST segment depression in lots of places. Or this anterior, see this ST segment's down. That's just a sign of ischemia, quite widespread ischemia. Whereas this V1 is normal, that isoelectric line's maintained, but most of the other leads show ischemia. As opposed to infarction, where the actual is a full blockage, and that's an evolving process. Normally, you've got this pre-event, which is a normal ECG complex. The first thing that happens is the T wave gets dragged up, and that's the sort of thing we don't see much. That probably happens at home when the person's getting their chest pain. By the time the ambulance comes, they come to us or they present to general practice saying, look, I've got some chest pain. There's probably going to be ST segment elevation. And over the next hours and days, that will evolve to the only thing that's left is a Q wave, which is actually indicative of myocardial necrosis. So there's lost heart muscle there. So that heart muscle is gone, and so there's nothing to record, and so there's a negative deflection. This is an ECG of the inferior myocardial infarction, ST segment elevation myocardial infarction, inferior being, as we said, 2, 3 and AVF, this ST segment elevation. That would be an acute infarct. There's no Q waves yet. There's this ST segment depression, which is probably related to, it also involves the posterior side of the heart on this particular ECG, but for the moment, we'll just focus on these 2, 3 in AVS. So this is an inferior myocardial infarction involving normally the right coronary artery, and we'd expect complications such as some heart blocks. This is a more evolved one where you've got the establishment of these Q waves. So it's an older one. If this presented, we expect this person probably would have had pain the day previous or probably greater than 6 hours because they've actually got all these heart muscles dead. Whereas this, if they get taken to the lab, they'd have minimal damage because they haven't had that damage yet. And this is an anterior infarct. So once again, anterior, we go across to our chest leads and we get this ST segment elevation in these anterior leads. Anteroseptal leads is quite marked ST segment elevation. And at hospitals in metropolitan areas, they would come in by ambulance and go to the cath lab and hopefully we'll be able to open up that artery. That would be the left anterior descending artery. And that can cause a lot of damage. So people who have big anterior infarcts would do worse than inferiors because there's just more myocardium involved and it tends to involve, just more myocardium, greater incidence of heart failure. So that's ischemia and infarction. We'll just move on to some common arrhythmias. As I said, and I'm a big fan of this, just keep it simple. It's either fast or slow, and really what type it is, it doesn't really matter. So the bradycardia is anything less than 60. Of course, that depends on age. Tachycardia, often you'll see, if it's above 100, but really if someone's sitting in a bed and their heart rate's 96, you think, well, that's odd. Like it shouldn't be that high. So, some of the cardiologists I've spoken to, they say really you'd want to think anything above 90 is a bit odd. So tachycardia might indicate something's wrong if it's above 90. So it doesn't really matter if it's fast or slow. The symptoms are often similar because it affects cardiac output. If it's too fast, they're not going to like it. It'll affect cardiac output because it can't fill. Too slow and it's just not fast enough to be maintaining their blood pressure. So people can present to a general practice with falls, fainting, syncope, dizziness, confusion, sensation of beating heart, palpitations. That could be through bradycardia or tachycardia, chest pain or angina, and shortness of breath and fatigue. And certainly shortness of breath and fatigue can be associated with lots of things, but it's also a chest pain equivalent. People with diabetes, older people, women, often present atypically with their symptoms of myocardial ischemia, and shortness of breath is something we take very seriously. So all these would be an indication for doing an ECG, and they're also symptoms of maybe a fast or slow heart rhythm, as well as the symptoms of ischemia or infarction. So this is an example of normal sinus rhythm. So from the SA node, depolarizes the atria, gets slowed down the AV node through the His-Purkinje system, super quick. You notice there's a normal P wave. This QRS is nice and narrow because that's super efficient and quick. Atrial fibrillation, on the other hand, is where we have its most common abnormal heart rhythm, and you'd see this a lot in general practice. A lot of elderly people get atrial fibrillation. The incidence increases with age. Got a 1 in 4 chance of getting it after the age of 40. And that's where there's this uncoordinated electrical activity in the atria, resulting in fibrillating. There's no discernible P waves. It's irregularly irregular. That's the key point with it, irregularly irregular with no P waves. Some people don't know they've got it if it's not too fast, but if it's too fast, they'll be complaining of palpitations, commonly associated with people with a heart pathology such as congestive cardiac failure, where they get enlarged atria. Atrial flutters are related arrhythmia. It's associated with the same complications, and that is the two things about atrial fibrillation and flutter is that it can cause strokes because you have stasis of blood in that atria, which can dislodge and go to the brain. And if it goes too fast, they're not going to like it. So we'll always concentrate on rate control, so slowing it down. As you can see, this rhythm is quite fast, and protecting people from stroke. And most people would be able to be put on a Pixaban if they don't have any other heart valvular problems. So Pixaban or Rivaroxaban, one of the oral anticoagulants. So they're very common. These are very common arrhythmias. Atrioventricular block, this is where we can get some problems in this AV node. As you get older, it gets a bit lazy, and all depends how much block there is. So normal will just go straight through with a bit of a delay. If there's more than a bit of a delay, greater than one large square, you get first degree AV block, but you get a P wave always followed by a QRS. If it gets blocked too much though, you have to start to drop the QRSs. So you get this P wave here without a QRS. So that's a second degree AV block, various types, which I won't go into. And then there's a third degree where you have the atria doing its thing and the ventricles are doing their thing, and there's no communication between the two. Because the ventricles are sort of given up on the whole thing and they're just taking control of things and they're just setting their own pacemaker rate. And you can see there's no relationship between these P waves and the QRS. So it's called AV dissociation. But they're just doing their own thing. And because the pacemaker rate for the ventricles is slow, there's normally a bradycardia involved. And these people often present with, fatigue, fainting, dizziness, presyncope. You can look at premature atrial contraction. So this is a normal sinus rhythm, but you've got these extra beats here, but they're narrow. But that's just a premature atrial beat. You can also get premature ventricular beats, but they're wide. So they're coming from an ectopic focus, such as down here. Because they're not going through this specialized conduction system, and because we know this horizontal line is time, it's taking it a long time to contract, a long time to depolarize. And that's because it's having to go cell to cell. So that's how you can tell a ventricular ectopic, it's wide. So it's greater than 3 small squares or 0.12 seconds. And that's just because it's not utilizing that highly efficient conduction system. Sometimes you get multifocal, so they look different. And I suppose the thing with that is it's often the sign of the heart's irritable. When someone's having a heart attack, if we see just one complex that looks the same, not too worried. We think, oh, well, that's okay. But if you see lots, it just means the heart's irritable. It's normally irritable because it's ischemic, it hasn't got enough blood supply, and so that would be a precursor to maybe them arresting. So if you start seeing lots of ectopics, that's probably not as reassuring as if you just had the same configuration, which is coming from one spot. But the more spots, the more irritability there is. So you'll often see these, it's just how many and if they're unifocal or multifocal as to their significance. Lots of people have pacemakers, all different types. What type? They can have atrial pacemakers, ventricular pacemakers which are defibrillators as well, pacemakers that pace the right and the left ventricles. And also we've got a newer one, the Micra, which is actually just like a little tablet that just gets put into the right ventricle. And that's like a leadless one. Only for certain people. So you can see these pacing spikes, that's the giveaway with these. These are atrial pacing spikes, and you've got the P wave being formed. These are ventricular pacing spike causing the ventricles, that's wide because it's coming from the pacemaker and not through the specialized conduction system. And this is where if it slows down too much, the pacemaker cuts in. So these are 2 normal beats, waited too long, so the pacemaker's probably set to 60. As soon as it hits 60, it flashes and acts as like a backup. We've got some tachycardia, some VT, that normally comes a repetitive firing, either from one focus, or you can get a re-entry circuit due to scar tissue. And that's where you have once it's wide and it's fast. Anything that's wide and fast can be VT. It's not always VT, but that's what you should be suspecting. Because once again, people aren't going to like that heart rate. Once again, it doesn't really matter what the rhythm is. If it's fast, it's probably not good. So it's tachycardic, it's going very fast, probably 150, and they're probably going to be compromised by that. But that's a broad complex tachycardia. And then, of course, we've got the old ventricular fibrillation, which is going to require emergency defibrillation. So that's a little bit of an overview of just ECG, how to take an ECG, looking at the ischemia in infarction features, looking at some common arrhythmia. The most common one you're going to see is atrial fibrillation, irregular. People need to be rate controlled and on anticoagulation to prevent stroke, because it is a leading cause of stroke. And now I thought we could do a little bit of a case study and a multiple choice. I think, was Bertha going to help with this?
Yep, I've just launched the poll.
Okay, excellent. So we've got this rhythm here. And so if we look at the features of it, it's sort of narrow. So it's a fast rhythm. It's going pretty fast. Hard to say exactly what, but I'd say it's going probably above 150 a minute. It's irregular. There's different RR intervals. And please choose which one you think it might be. Right, okay, there's a few answers here. The majority of them are broad complex tachycardia. It's not that broad, like that's actually a narrow complex, that's less than one small square. So that would be a normal duration complex. So that's coming from above the ventricles. So it's but it is irregular, and that's a feature of atrial fibrillation. So we've got no discernible P waves. There's all these extra waves, but nothing's really convincing as to a regular P wave between the QRS. The key giveaway is it's irregular, and it's fast. So a fast, narrow heart rhythm that isn't regular, put your money on atrial fibrillation. And you can't really discern any proper P waves. There's all this sort of activity, but there's not an obvious P wave before each QRS. So atrial fibrillation. Okay, case study 2. So this is Sylvia Anastasio, 78-year-old lion tamer, complaining of frequent dizziness and some nasty scratches. Once again, we've got 4 choices, and we'll see what people think. Atrial fibrillation, complete heart block, broad complex tachycardia, possibly VT, or sinus rhythm. Majority are saying complete heart block, which it is. So complete heart block. It's complete heart block because there is regular QRSs, there's regular P waves, but they don't have anything to do with each other. So it's not atrial fibrillation because it's regular. It's not broad complex tachycardia because it's not really fast, it's going quite slow. But the ventricles are firing independently of the atria. So you can see there's no relationship. The P waves are doing their own little party, and the QRSs are just solidly just going on. Now, if this pacemaker, if this ventricular pacemaker decided to speed up, well, yeah, it would be VT, but it's not. It's a ventricular pacemaker, but it's going slow. So this is a complete heart block. So we just call this, complete heart block AV dissociation. Complete heart block. This is the last case study 3. This is Peter Risk Taker, 65-year-old trapeze artist who has a 2-week history of intermittent dizziness, and he's been falling off his high wire. Atrial fibrillation, complete heart block, broad complex tachycardia, possibly VT, or sinus rhythm. Think about the rate and think about the width. broad complex tachycardia, fantastic, yes. So it's fast, so it's tachycardia, and it's broad. You can see this curious complex is quite broad. So yeah, that's excellent. That was 100% for the last one. So well done. I'm just conscious of the time. We've got a few more of the quizzes to do. I'll take advice of Jan.
Hi, Glenn. Yeah, we have a little bit of time left. We've got a couple.
Okay, we'll just do a few.
Yeah, so we can do.
If there's questions, we'll take questions.
Yeah, did you want to do this one or do this case study?
Yeah, we finished this one. That's fine.
Okay, we've got a couple of questions. When with the putting the not clinical, so it's gonna sound funny. So they were talking about breast implants and placing the
yeah.
Yeah.
I think it's not an exact science, and I think you just do what makes sense at the time. As I said, this is a really common question, like women with large breasts, where to put those chest leads. As I said, the limb leads are pretty straightforward. The chest leads often cause more problems. I would just go for whatever's the most anatomically correct. So you track down the intercostal spaces, so fourth intercostal space, either side of the sternum, mid-clavicular, but you just want them to not be too far apart. Like if you find that in order to get under the breast, you're having to move V4 about, 30 centimetres or V3, if you can do something else, that's good. But I think everyone's going to understand if it's a difficult anatomy, you just do your best. So to have it so it's anatomically correct. So where that electrode is, you're trying to have that as close to where it should be as possible, whether that's on top of the breast or below the breast, whichever you can do. And probably, as I said, if 3 people had a go, they might have 3 different interpretations. But I think you just do your best.
Thank you. And another one around the placement of the leads is, are the lower limb lead placements on the lower abdomen affected by the large abdomen or abdo-apron?
Yeah, I mean, I suppose you just want to get in the lower abdomen's fine. If you get someone who's really obese and has a large apron, you would. It's sort of similar to the breast question, really. It's sort of you just got to see what makes sense. Once again, the right arm, the left arm is going to be quite straightforward, I think, with most people. But yeah, if you've got a very obese person, sometimes it can be difficult. You just want it to be low enough that you're going to be able to be below the heart, and hopefully it's going to, most people you're not going to have a problem with, but people who are particularly obese, that can be problematic. And I would just, if it's reassuring, there is no consistent pattern to how people do this. Excuse me, at St. George. So yeah, so just do your best as long as it's reasonable. If you want to put it on their legs, you can pop it on their legs. You want to put it on their upper thigh, you can pop it on their upper thigh. The important thing is that you get a trace that's good, and that if you do repeated traces, you have consistency with placement, whether that be on the chest leads or whether that be in the limb leads. But I understand sometimes the anatomy can make things, not as straightforward as a perfect mannequin with with great abs and pecs. So, yeah.
Okay. We've got another question here, Glenn, around some troubleshooting tips. Just around if you're having problems getting a clean ECG reading, that quite often that they're getting usually some sort of artifact or AC noise. They've tried replacing dots, asked patients to remove any electrical devices and jewelry. Do you have any tips if we can't get a clean ECG reading?
Look, sometimes it can be very frustrating. I think going back to the preparation, so if you feel as though you've actually prepared the skin well, I think shaving is really important. That's something that can sometimes be problematic. Make sure the skin's clean, good quality electrodes, take your time, make sure the patient's relaxed. They're the key things. Now, every now and again, it's going to be particularly difficult. Often that's because, and sometimes it can be difficult if they've got clothes on, they're just taking, if you're trying to take shortcuts, I think it's hard. If you just want to expose a little bit of their chest. So I suppose, once again, it comes back down to the preparation. You might find that if you've done everything right and and you still can't get a good trace, well, sometimes you can't get a good trace. It might be that person. But most of the time, if you revisit it and think, okay, I'm just starting from scratch, I'm cleaning the skin, I'm getting new electrodes, I'm going to take my time, I'm going to tell them to relax, I'm going to make sure they're not shivering, make sure they're warm. Those sort of things are the troubleshooting issues. Whether that's going to solve 100% of the problems, probably not, but it should solve 99% of the problems. So I would always go back to your basics, and barring that, get another ECG machine. But sometimes there is the occasional person, but normally from my experience, it's something I'm trying to take a shortcut with. And then I think, can't take a shortcut.
Great, thank you. And if we're doing an ECG on a child, do we do it the same way as we do an adult, say if we have a 5 to 12-year-old? Yeah.
So you would still do the same anatomical markers. Yes, you'd still do the same ECG. Of course, they're going to have different heart rates and things. But, so the interpretation would have to be in the context of someone who's 3 months old or 4 months old. And obviously, there are pediatric dots, pediatric sort of electrodes as well, because, because kids are little, or depends how little they are. But certainly an 11-year-old or something like that would be fine. The existing electrodes will be fine on 11-year-old. But when you're talking about a baby, I think things get a little bit trickier with how to fit them on the chest. But the anatomical landmarks would stay the same. It's just that whether the electrodes are going to fit on the actual physical size of the person.
Okay, thank you. Another question here that's come through is, how is the bottom line on an ECG generated? Is it generated as a combination of the V1 through to 6 plus the limb leads?
Is that the report that goes on the ECG? Is that the report of the report that's generated, or
so
when we're looking at a...
Yeah, sorry, Glenn. Go.
So if I was looking at an ECG, I would just look at all those limbs because I want to see all the views. And we're looking, I want to see the inferior views, I want to see the anterior views, the lateral views, because all those make sense in terms of you want to see if there's any areas of ischemia or infarction. The algorithms on the ECG machines, which sometimes spit out this is sinus rhythm, or this is a heart attack, or this is atrial fibrillation. Normally they have an algorithm. It's called the Glasgow algorithm. That's what they use in a lot of the ECG monitors. And they're fairly accurate, but then by no means 100%. By no means. I mean, they will be wrong most days that I look at them, but they're worth sort of looking at, but they're not infallible. That's just an algorithm, which I know it's a computer algorithm, which they put in. It's an international standard. And a lot of the ECG machines will use that. It's called the Glasgow algorithm. It's not the Glasgow coma scale, it's the Glasgow. So a lot happens in Glasgow. But as for me, so a rhythm strip's good, just looking at what rhythm they're in, what heart rhythm they're in. So it looks at, is it in sinus rhythm, or is it in AF, or is it in whatever? But the 12-lead ECG gives a lot more information in terms of the structure of the heart, so where there might be ischemia infarction, the location of that. It'll also give an indication as to hypertrophy. So if you've got really large complexes, it can be a sign that's often seen in certain leads. It can be a sign of left ventricular hypertrophy or atrial hypertrophy, which is much more useful, which is much easier to look at with multiple leads. Because one lead only gives one view. It's good, you know, so you can tell what type of car it is if you're liking it to a car, but you can't really tell about all the features of it. So in order to look at the features of someone's heart, a more comprehensive view, that's where the 12-leaded ECG is essential, because nothing can hide. Well, try not to hide anyway. But it's much more useful to have a 12-lead ECG. The algorithms on the ECG machines are good, but they're certainly not infallible. But certainly if they say it's an infarct, it will detect the ST segment elevation. And whilst it may not be an infarct, they certainly should be taken seriously and be followed up by someone in person.
Great, thank you so much. We've just got one final question here. It's just around the settings. So would you recommend changing the settings on an ECG machine? There is a setting for reducing the AC noise, but does this does that reduce it? They can't tell if it sort of then changes the accuracy of an ECG.
Oh, look, I think if you find there's lots of interference, electrical interference, you could try that filter. It won't really interfere too much with the accuracy. If you're happy with the trace, it's still fine. It should be at 25 millimeters a second. So most things are standard, which you shouldn't change. If there is a filter, you can use the filter if you're having problems with interference. But if you can avoid using that, if you don't have to use it, you don't have to use it. Ideally, you shouldn't need it. So any of the filters, any of the machines, they're not meant to, they're meant to do a good ECG, you know, and my argument would be that if you need to put a filter on, they should put the filter on all the time. But the ECGs, most of the ECGs about now are pretty good. And ideally, they've already got filters on them, which are acceptable. And if there's additional filters, if you need to use it, give that a crack, because otherwise if you're not happy with the trace, you're not happy with the trace. And you can try that additional filter and you just make sure you document that filter was on. I don't think it'd make a great deal of difference. You'd still be able to see the rhythm, you'd still be able to see the ST segment elevation. It's just maybe it might dampen things a little bit.
Okay, great. Thanks, Glenn. That's all the questions we have for the moment. Thank you.
Okay, I think we've come to the end. Thanks, Glenn. Thank you so much, Glenn, for presenting tonight. And thank you for attending, everyone. Did you want to say something, Glenn?
I was just going to say it's such a pleasure. Like, it's so good to interact with practice nurses. It's a real focus of a lot of the CNCs at St George, that we try and get more time and more interaction with our primary health colleagues, and it's always a joy. So, and I'm always happy if anyone wants to phone me up or ask me questions or want to discuss anything about ECG or cardiology, please, you know, just reach out, and always happy to chat, because, you know, all part of the team.
That's great, Glenn. That's really great. Thank you for that. Thank you, everyone, for attending. We'll be planning our St George Hospital webinar series for 2025 soon. So please keep an eye out on our event page on the website, in our Sydney Health Weekly e-newsletters, and also the fortnightly practice nurse update that Michaela does in our newsletter. Please also remember to complete the evaluation survey, and we appreciate your feedback and ongoing support. Thank you so much, Glenn, Bertha and Michaela, and everybody else. Have a great night, everyone.